Professor Kirit sir, good evening, sir. Sir, I request you to run that second case of varicose veins because my network is not that very good today, sir. So, candidate is joined and I have trialed him. He's able to connect without much of a challenge, sir. If I get lost in the connectivity, please run the program, sir.
Done, sir. Done. Okay, sir.
Thank you, sir. Thank you. I think we are 8 o'clock. Good evening, friends. We warmly welcome the invited faculty for the day. We have Professor Venkatrami Reddy, sir, Dr. Johnson, Professor Johnson, Professor Bharat, and we have our own faculty, Professor Kirit Parmar. And then we have two eminent bright students. One, Dr. Indranil, kindly contributed by Dr. Samir Rege from KM at GS Medical College, Mumbai. And Dr. Kamran is kindly contributed by Professor Babu Antony and Professor Anandi Ma'am at Government Stanley Medical College. So, Professor Kannan sir, good evening, sir. We start the first case. The first case will be the obstructive jaundice, then the varicose vein. For next week, we have the portal hypertension. Today, for some reason, the boy is still held up in the OT. So, we will have the portal hypertension case next week. So, good luck to you. Kindly take over faculty. Dr. Indranil, please introduce yourself, your unit chief, head of the department, and then start your presentation. Good luck to you.
Thank you, sir. Good evening, everyone. I am Dr. Indranil from GS Medical College, KM Hospital. My unit chief is Dr. Samir Rege, sir, and my PG guide is Dr. Yogesh Takalkar, sir. I'll be presenting today on the topic obstructive jaundice. I'll be sharing my slide. Is it visible? Hello.
Yeah, we can see.
Okay, sir. So this is a case I'll be presenting on obstructive jaundice.
Yeah, please go ahead.
Yes, sir. My patient, a 50-year-old gentleman who presented with complaint of yellowish discoloration of skin, sclera, and had pruritus since the past 15 days. So this 50-year-old gentleman, who was a resident of Bihar, was apparently all right 15 days back when he noticed yellowish discoloration of skin, sclera, and there was itching all over his body, which was insidious in onset and was progressively increasing in a continuous manner. He also had a history of significant weight loss, which was 8 kgs in a month, the past month. There was no history of any waxing or waning jaundice or intermittent jaundice. There was no history of clay-colored stools. There was no history of past blood transfusions, any malaise or low-grade fever. There was no history of easy fatigability. The patient did not complain of any sharp pain in the right hypochondric region or any pain radiating to the back. He did not undergo any procedure previously. There was no history of ERCP or laparoscopic cholecystectomy. He did not complain of hematemesis, melena, or silvery stools, and did not have a history of early satiety. He did not have any easy bruisability or petechia over his body. There were no complaints of high fever with chills. There was no disturbance in his sleep, bowel, or bladder habits. He did not have any comorbidities and denied any addictions. So to summarize it, my patient is a 50-year-old gentleman who was apparently well 15 days back when he noticed yellowish discoloration of skin, sclera, and pruritus associated with high-colored urine, which was continuously progressive in nature, which was not associated with any clay-colored stools or fever. On general examination, which was done.
Can you just hold on there? Go to your summary.
Yes, sir.
Okay, it's only 15 days, no?
Yes, sir.
Yeah, 15 days, and then you're telling there is a pruritus, but there is no associated clay color stools.
Yes.
Okay. So what do you think from the history it is? I mean, do you think any history is missing in the what is given to you? I think it has been given to you, no?
Yes, the patient did not complain of any pain or
Any,
like
any history is missing? Nothing.
he did not complain of any pain like localized pain in the RHC
So,
region, sir.
yeah, so to summarize, it's a painless progressive jaundice. That's
Yes,
what you meant.
yes, sir.
Okay. So what do you mean by intermittent jaundice? You said there is no history of intermittent jaundice. What do you mean by that?
Intermittent jaundice is that in which the bilirubin levels rises, but it falls below the baseline level of 2.5, above which it is clinically evident. So
Hmm.
there are intermittent episodes of jaundice-free period in intermittent jaundice.
So where do you get that?
In choledocholithesis, in which the stones are intermittently passed, and when the stones are passed, there is a jaundice-free period. After which, again, if there is a choledocholithesis, there might be development of obstructive jaundice yet again.
Okay. Anywhere else you can get?
What is the difference
Maybe I'm
between
very
obstructive jaundice and surgical jaundice?
Uh, Obstructive jaundice is there is any obstruction to the bile outflow. There is in the biliary tract. And non-surgical jaundice is there might be a hemolytic or a hepatocellular jaundice, which might be the cause of the.
Sir asked I think
Uh,
he asked what is
asking
obstructive and surgical, difference between
Oh,
obstructive and surgical.
oh, sorry, I heard medical. Um,
Both are same or different?
mm, Mostly
can you get obstructive jaundice in a patient with a viral hepatitis?
um, viral hepatitis patient, they might so
What
that
do you
might be a medic.
what do you mean by cholestatic jaundice?
There is a stasis to the bile outflow. That is the viral inflammation that is causing stasis of the bile. So that is the reason the bilirubin levels increase and the direct bilirubin rises.
So is that a surgical jaundice?
Uh,
Cholestatic jaundice is a surgical jaundice?
no, sir.
So, Indranil, at the end of your presentation, what do you think it is? It is a surgical jaundice or a medical jaundice or an obstructive jaundice? What is your conclusion about this presentation, this summary?
This is an obstructive jaundice, sir.
Why did you say obstructive jaundice?
Uh,
What did there to say obstructive jaundice?
there's progressive, like the jaundice is continuously progressive, and there was also a history of loss of weight. So there might be some.
What is that particular feature in your summary which says it is obstructive jaundice?
Mm,
Which are the points which are favoring obstructive jaundice, which are against obstructive jaundice in the history, just history.
we did not have any history of malice or any past history of blood transfusions or any history of
Yeah, that's all negative history. Or
yes,
what you have in the history in the summary, what you are seeing. What made you to say it's an obstructive jaundice?
the mainly the progressive yellowish discolorations, the high colored urine and the
That
pruritus.
we can get even in viral hepatitis. It can progress or acutely hepatic failure. Anywhere you can get, no?
One particular feature in your presentation which suggests that it is obstructive jaundice.
Pruritus, anything?
Yes, pruritus was present with.
So you know you can get in other cases, but it's more typical for obstructive jaundice. Is it so?
Uh,
Yeah.
So
Okay.
even
yes,
in viral hepatitis, if there is severe cholestasis, you can get pruritus. So that's why the sir was asking you whether it's obstructive jaundice or surgical jaundice. Understood?
okay.
And clay color stools? Do you get clay color stools or no clay color stools in
In
obstructive?
obstructive jaundice, clay colored stools are present, but in this particular patient, he did not complain of clay colored stools, because
So
maybe there was partial obstruction.
So, and it's a short history, no?
Yes, sir.
So, okay. So, what do you think it is now? Can it be still intrahepatic cholestasis?
Uh, Cholestasis, he did not present with any fever, sir, because in viral hepatitis, the
So,
fever is,
yeah, you didn't mention that. That's why I said anything missing, any prodromal symptoms. You never said that. Okay. It was not okay. No such history here. Okay.
What is acholeric jaundice? What is acholeric jaundice?
uh, I'm sorry.
Acholeric means in the urine, it is not yellow colored. So sclera is yellow, but urine is not yellow. So that can happen in hemolytic jaundice,
Yes, sir.
In hemolytic jaundice, you can get the acholeric jaundice. So why the urine is yellow in jaundice patient and surgical jaundice or obstructive jaundice?
In
What is the reason of yellow colored urine?
obstructive jaundice, there is an increase in the conjugated bilirubin, which is water soluble and which passes in the urine as a result. As a result, there is a high coloration of the urine.
Okay. Right.
Okay. What do you think your probable diagnosis if it's an obstructive jaundice? What do you think the cause for that? Do you think it's benign or do you think it's malignant? If
Based
malignant,
on the history that the patient gives her, he had a history of weight loss, which was significant,
yeah.
along with the progressive nature of the jaundice. So this
Okay.
might be malignant, sir.
So when you
Most
say
of,
progressive nature of the jaundice, did the
Yes, sir.
patient notice that initially it was light colored and now it's
Yes.
high colored?
Yes, sir.
Why did
Can
you ask the history of blood transfusion in this patient?
Because, sir, if it is a hemolytic jaundice, the patient will have repeated episodes of blood transfusion in the past in view of anemia. And if it is a case of viral hepatitis that's causing jaundice, then the blood transfusion might be a reason for the viral hepatitis. So that is the reason I asked for the blood transfusion, sir.
How many days after the blood transfusion the patient get the hemolytic jaundice?
It's generally a month later, sir.
Hmm?
3 to 6 months later.
3 to 6 months later of the blood transfusion.
that is because of what? 6 to 6 months later, what will be the cause usually?
Usually, after blood transfusion, if it is viral hepatitis, it might be due to
Hmm.
hepatitis B or
Yeah, but initially you can get.
Okay, within 24 to 48 hours. Once the hemolysis is there,
Yeah.
okay, hemolytic jaundice is because the hemolysis is there. So there's a mismatched blood transfusion is there. So within 24 to 48 hours, initial PD you will get because of that. And usually after 4 to 6 weeks, the incubation period for the hepatitis is about 4 to 6 weeks. We will get at that time there. Okay.
Yeah. So what malignancy do you think in this case probably?
in this case, it might be a this is most distal cholangiocarcinoma. In this case, or a periampullary carcinoma might be the reason for this jaundice.
Why you
Okay.
are thinking of the periampullary carcinoma here? Based on the history, it's a progressive jaundice.
Uh, Mostly it is not going towards periampullary, sir, because in periampullary there is also a history of hematemesis and melena, and intermittent episodes of silvery stools are present in periampullary carcinoma.
Which is
It
more
So,
common? Periampullary
yeah.
carcinoma is more common or carcinoma head of pancreas is more common?
uh, periampullary, sir.
Periampullary is more common.
But this is too short, to have
15
such
days.
this thing, aspiration. Hmm? So you may not get that melena and then waxing and waning in 15 days. Okay.
On general examination, which was done for the patient in a well-lit room after taking informed consent, the patient was conscious. He was oriented to time, place, and person. He was obese with a BMI of 31.25. He was afebrile. Vitals were stable with a pulse of 86, blood pressure of 120 by 70. Saturation was 98% on room air. Respiratory rate was 16, and the blood glucose was 112. General condition of the patient was fair. Icterus was present. There was no evidence of any pallor, clubbing, cyanosis, lymphadenopathy, or edema. He had scratch marks present over bilateral lower limbs. There was no foul-smelling breath and no additional discolorations or lesions which were present over the skin. Other systemic examination was normal. On abdominal examination, after getting proper consent from the patient and adequate exposure under well-lit conditions, inspection was done in supine position. The umbilicus was central and inverted. Abdomen was normal in shape. There was no localized fullness, scar, sinus, or dilated veins. There was generalized yellowish discoloration of the skin present, and all the quadrants were moving equally with respiration. On palpation, which was done with the patient in supine position with hips and knees flexed. On superficial palpation, the abdomen was soft and non-tender, and there was no localized rise of temperature. On deep palpation, there was no palpable lump, no hepatosplenomegaly, or no cuff impulses were present over the hernial orifices. On percussion, the liver span was normal, and there was no shifting dullness. And on auscultation, the normal bowel sounds were present. I also did a rectal examination for the patient. There was no melena, and it was roomy with yellowish stool staining and normal tone. So provisionally, so this is a case of obstructive jaundice, probably due to malignant etiology. After, yes, sir.
Why do you say malignant etiology? Short history, 15 days, no loss of weight, no loss of appetite. Patient
So
is
there,
obese, well preserved.
so he was obese, but he had lost significant weight. Had a
Okay,
weight of
yeah.
72
You said
kilos, and he had
88
lost.
kilos, you said, no? 8 kilos
Yes,
weight.
sir. 8 kilos in
Oh.
1 month.
Okay.
After which I would like to do some investigations for the patient.
No, we'll
No.
stop there. I mean, I
Yeah.
think we
With
need to.
examination, what do you think your diagnosis now? You should have some provisional diagnosis now.
Provisionally, sir, the provisional diagnosis of the patient, it might be a distal cholangiocarcinoma. It might be a periampullary carcinoma.
So if it is a distal cholangiocarcinoma, what findings would you expect in this patient while examining him?
There might be a lump in abdomen, but it would be painless. But in this patient, sir, the lump was not palpable.
What do you refer to when you say that lump? What is your idea behind that lump?
It is the lump might be due to the palpable gallbladder, sir.
So if you say distal cholangio now, and if you don't find a palpable gallbladder, what
Yes,
does it suggest?
it is not completely lumen occluding, sir.
Or else? Or else? It's an obstructive jaundice. You are saying cholangio, but gallbladder is not palpable. So where do you want to put the lesion?
It can also be higher up, like say in flat skin tumor or
No, that's what do you want as a first thing, what do you want? See, it's not seen, not felt is a different thing. With these clinical findings, you should put your lesion first, no? Where do you put? Above the cystic duct opening or below the cystic duct opening? What?
If it is not palpable, it would be above the cystic duct, sir.
So, but you have been telling all the while it's a distal cholangio. What made you say it's distal cholangio then? With your clinical findings, distal cholangio is a distant possibility, not the first possibility. Yes or no?
Yes, sir, it's a distant possibility.
So what other reasons can be there in your from your clinical examination? What other possibilities can be thought about?
It can be a hilar cholangiocarcinoma, sir.
Okay.
Or it could be a Choledochal cyst.
Choledochal cyst.
Yes, sir.
But
Why
you're
would you
telling
say that?
malignancy, 8 kilos weight loss.
Why,
Yes,
why
sir.
would you say choledochal cyst? What made you say that?
Because of the obstructive jaundice mainly, sir. Other findings,
So what's the primary feature of a choledochal cyst? Is it obstructive jaundice or something else?
it,
Does choledochal is present like this? Progressive, painless,
no, sir.
jaundice. You said something else, no? You're intermittent and all that. Something.
Presence in sometimes in cholangitis, and if there's obstruction at the
Yeah,
distal.
weight loss is something which is against.
Yes, sir.
Progressive is one something which is against. Okay. Until unless it has developed a malignancy in that cyst and.
Yes.
Okay. What
Why not
else?
carcinoma of the gallbladder?
It could be carcinoma of the gallbladder, sir, but if the since if the carcinoma extends like into the common bile duct and obstructs the bile duct, then it would cause obstructive jaundice. Otherwise, it could present as a lump.
What are the causes of jaundice in carcinoma gallbladder?
There might be some metastasis into the liver, sir, in case of carcinoma gallbladder, which might be a cause. There,
How severe it should be for a metastatic disease to cause obstructive jaundice? Where, I mean, see, if there's a metastasis to the liver, do you think that patient present with obstructive jaundice?
no, no, sir.
So where should be the metastasis to?
It should be to the bile duct, sir, in case of gallbladder carcinoma, for it to be obstructive jaundice.
Okay. So that's a direct infiltration, would you say, we are trying to tell, is it? That
Yes,
won't
sir.
be called metastasis, no? It's a direct
No, sir.
infiltration.
Yes, a direct infiltration.
So what do you mean by metastasis in this case? Where does the tumor metastasize to other than liver?
To the lymph nodes, to the
Yes.
periportal lymph nodes, to the peripancreatic lymph nodes, and to the aortocaval lymph nodes, sir.
So that can cause obstructive jaundice then?
If the spread to the nodes is causing compression upon the bile duct, then it can lead to the obstructive jaundice.
So in your differential diagnosis, after your cholangiocarcinoma, can you think about any lymph nodal masses obstructing that bile duct there?
Yes, sir. If it's a case of gastric carcinoma, which is causing periportal metastasis, which can cause obstruction and can lead to obstructive jaundice.
So now you're saying that this patient has gastric malignancy with lymph nodes, is it?
Not this patient, sir. In
No, we're
this
talking
patient, he
about
did
this
not have.
particular patient. We are talking about this particular patient. What are the other differential diagnoses is the question. So we started there. Okay. So can you think about any lymph nodal mass in that area obstructing the bile duct is the question I'm asking.
There might be a lymphoma, sir, but it did not have any like systemic features. There was no lymphadenopathy present in other areas of the body.
What kind of lymphoma are thinking here? What are the causes, few known causes for periportal lymphadenopathy? Can you remember any?
There can be tubercular cause, sir. And apart from that, it might be distant spread of a tumor. Uh,
So
there
the
can,
question, the problem here is you have a patient with obstructive jaundice.
yes,
You don't have any palpable mass. No, liver is not enlarged. No palpable gallbladder. Okay. So now you need to fix the location of the tumor, right? So that's
yes,
why we are doing this exercise. But you started saying that it is distal cholangio, which we didn't agree to. Because if it is distal cholangio, we would expect a gallbladder to be enlarged and palpable, right?
yes, sir.
So now we need to fix the lesion where there is no palpable gallbladder, yet patient has obstructive jaundice. That's what we are trying to understand.
Yes, sir.
Yes or no?
Yes, sir. It can be a flat skin tumor, sir.
Yeah, that you already told. Yeah. Apart from that, any other things which can come to your mind is the question.
Any disease of the gallbladder? Any disease of the gallbladder?
Revie syndrome, sir.
Where gallbladder is not palpable. A
Not
shrunken
palpable, yes, sir.
gallbladder.
If the gallbladder is not palpable, then there might be choledocholitis and chronic cholecystitis, but so that would be a benign cause.
So why are you
Patient
so fixed on it being malignant? That's the question
Yeah.
I'm asking. Why are you so fixed on it being malignant?
Mainly because
Except for his weight loss, which is 8 kilos,
no,
according to you. Apart from that, is there anything in the history which says it is malignant or not malignant?
the
See,
jaundice was yes, sir.
whenever you are not clear about your diagnosis, you can
Yes,
always
sir.
put a differential diagnosis. And then you have to say which is the most likely diagnosis depending upon the findings, symptoms, and the clinical examination. Sir is asking the same thing only, that the gallbladder is not palpable. Then why you want to keep on asking except weight loss? The things are not clear. Then you have to put a differential diagnosis. What is Corvage's law?
If in a case of obstructive jaundice, the gallbladder is palpable, it is rarely due to a benign cause, sir.
Fine. So what are the fallacies of the law?
There might be if the gallbladder is palpable in a benign cause, it might be due to a double impacted stones, one in the CBD and one at the cystic duct. It might be
Yes.
due to Merezi syndrome.
Yes.
Yes, sir. And
Another patient is having malignancy, but gallbladder is not palpable. Then what are the
that,
different causes?
that might be due to a flat skin tumor or
One
something
is
above the
Klatskin
level
tumor,
of
true. Second,
yes, sir.
recurrent attack of cholecystitis. The gallbladder is shrunken.
Yes, sir.
2. 3. Patient might have undergone cholecystectomy. In your case, it is not done.
Yes.
In generally, we are discussing about the fallacies of the Corvage's law, where it suggests that there is a obstructive jaundice, but gallbladder is not palpable. And the last one is intrahepatic gallbladder, that where you cannot palpate the gallbladder, right?
Yes, sir.
Now back to our case. What do you think?
Since he did not have any previous history of lap cholecystectomy, possibility of a possibility of a post-operative stricture is ruled out, sir. And he did not have a palpable gallbladder, so it's going more towards causes above the level. If there is a malignant cause, it is going more towards the above the level of the cystic duct, sir, like flat skin tumor. And it might also be an intrahepatic gallbladder.
Let us keep the two diagnoses here. One is the proximal
Flat skin.
cholangiocarcinoma, and second is the carcinoma neck of the gallbladder. Okay, let us go ahead with these two diagnoses. What were the investigations done?
Yes, sir.
So what
Yes,
are the
sir.
investigations you
Yes,
want
sir.
to do?
Investigations, we did blood investigations for the patient. The hemoglobin was 12.5 and the counts were normal.
So that is the first investigation you want to do, the blood investigation in a patient of the obstructive jaundice.
No, sir, I would like to proceed with the sonography, ultrasound of abdomen and pelvis.
Okay, so what was the report of the ultrasound?
Yes, sir. The ultrasound showed the gallbladder distended with floods and the CBD was 18.1 millimeters at the porta with moderate central IHPRD. There was no evidence of any calculi in the gallbladder or the CBD.
And what about the pancreatic duct?
The pancreatic duct was not dilated, sir, in this case in the USG findings.
Specifically
the-
seen for that pancreatic duct?
Yes, sir. I mean, they did not mention about the but they did mention that the pancreatic duct was not dilated, and that there was
CBD measures 18.1 at Porta. What about
Yes.
the lower CBD?
The lower CBD.
They're dilated or not?
No, sir. Lower CBD there was tapering structure. A tapering structure was mentioned in the UHG in the distal CBD part.
So with this ultrasound finding, what is your diagnosis?
Based on this, there might be some obstruction in the distal part of the CBD, sir, which is the cause of the obstructive jaundice.
So that's the reason you have been biased initially, huh? So
Yes.
kept on saying distal cholangio. Why? So are you happy with the diagnosis? I mean, the findings which you found on the ultrasound. Are you happy with the, or you want to know more further, anything more from the radiologist? See, you mentioned only few points here. Gallbladder distended with sludge, porta, CBD dilated at the porta, and mild. What else you want to know from this?
I wanted to know about the pancreas, whether there is heterogeneity in the pancreatic parenchyma, or there is any inflammatory changes in the parenchyma of the
Why?
pancreas.
Do you expect that in this patient? No, what do you expect in this patient, and are you happy with the entire report, or you want to know anything like sir asked? What about the distal CBD? It's not mentioned here.
No,
So
sir,
why that part is excluded in this?
I should have included it, sir. The distal CBD had a tapering structure which was mentioned
No,
in
if the
the
findings are written, you should have explained it. No, why are you concealing it from us?
Yes, sir.
See, you are not written, but what are the findings of distal CBD? You are not written here, but what are the findings?
It showed a tapering structure, tapering distal CBD. The dilatation was present 18.1, which was maximum at the quota. But the distal CBD part, the size of the luminal size was 8.3 millimeters distally. And they had mentioned tapering structure.
So
in the US.
gallbladder is distended with sludge, and
Yes, sir.
CBD there is a tapering stricture. Can it be inflammatory stricture post the passage of stone?
Yes, sir.
So what do you expect in a case of benign stricture and malignant stricture? How will you differentiate these two from the ultrasound findings or radiological findings?
Radiologically, some malignant structure there might be irregularity. Benign structure would be smooth, and there will be smooth distal tapering in a case of benign structure, and in case of malignant, that might not be the case. There might be irregular contours.
So what's it called? How do they describe it radiologically? How does a sonologist describe that particular lesion in the distal CBD if it is malignant? For benign, you said smooth tapering. What about malignancy?
Malignancy has the irregular, like the structure which was smooth in case of benign. That is not the case in the case of malignant structure.
What's
It
the
is
opposite
irregular,
of that?
sir.
What is the opposite of that? Abrupt cutoff,
Abrupt cutoff, yes, sir.
shouldering signs. Okay.
Since here we are discussing the ultrasonography, on ultrasonography, most of the times it is difficult to comment upon the type of stricture at the distal end of CBD.
Yes.
Right. So
Yes, sir.
what next investigation would you like to go for after this sonography report?
I could have gone for an endoscopic ultrasound, sir.
Blood investigations? You don't want
Yes,
to
sir. Blood investigations were done, sir. In the blood investigations, the total bilirubin was elevated. It was 18, and the direct bilirubin was 13. And the SGOT and FCPT were mildly elevated. The ALP was 770, and the INR was, it was not deranged based on our reference values, sir.
So what is your inference from that? Bilirubin 18, SGOT elevated, SGPT elevated, ALP elevated. What does it
If
suggest?
the SGOT and SGPT had been very like elevated in the level of thousands, then it might have moved more towards hepatitis called
No, what is this? You comment about
What
this
is your
and
inference of this? You tell me.
this you tell.
based on this, it's an obstructive jaundice due to some CVD pathology due to some obstruction at the common bile duct level. That is the
What?
reason the direct bilirubin is elevated.
So SGOT 130, do you think that's a significant elevation or non-significant elevation?
It is mild elevation, sir.
So why do you say it's mild? When you think that it's significant?
In case of hepatitis, viral hepatitis causes the
Now,
SGOT and
what value of SGOT would prompt you to say that it is a significant elevation? Now, whatever value you are seeing here, is it significant or non-significant? How do you know that it's normal or abnormal?
more than three. It is if it is more than 3 times the normal level, then it is
So you should
significant.
also mention the lab normal values here. Okay. Otherwise, it is, of course, 130 looks really high. But then you should also mention the normal lab values so that for people to understand how much it is elevated. Understood?
Yes.
Okay. So which particular investigation, which particular report in the investigation would suggest you that it is obstructive jaundice? One particular
Direct bilirubin, sir.
that suggests you that it is obstructive jaundice?
And the ALP level.
Yeah. So what else you would want to do now? You have these reports with you. So what is your next line of approach?
Based on this, I would like to stage the patients. If
Stage.
they,
You already went to stage. Do you have a diagnosis in your hand? Come on. It looks like you are completely taken with the, you know the reports. So this is the problem, no? See, in examination, you will find it really tough for yourself if you speak like this. You are jumping to the final reports already. We haven't had any discussion on that. We don't know the diagnosis that you are talking about staging. What staging are you talking about? What is the diagnosis you have in your hand right now?
US is only showing the tapering of the CBD, dilated
yes,
CBD. That's it. Sir is asking that what next? How will you diagnose? Then comes the staging. Is it benign, malignant? At what
uh,
level the obstruction, type of obstruction? How you can make out?
With the ultrasound report you showed us, would you want to stage the disease?
no, sir, not based on
Then,
that.
then tell us what else can be done to identify the problem. No, we haven't diagnosed the problem yet. We
Yes,
know
sir,
that the bilirubin levels are high. That looks like an obstructive picture. You have a ultrasound report showing that IHBRD is there and bile duct is dilated. But what is the lesion? Where is the lesion?
we can
Are you
go for a we can go for a CT scan of the abdomen, sir. CCTA plus P.
CT?
CCTA plus P, sir, for this patient.
What is A plus B?
Abdomen and pelvis, sir.
Yeah, please be specific. No, we will not
Yes,
understand
sir.
what it is A
Yes,
plus
sir.
B is.
Right.
Okay. So what kind of CT want? A plain CT?
No, sir, contrast enhanced.
Is there any specific way to mention that? Do you want to have just a contrast enhanced or more specifically something?
Uh, triple phase, sir.
Why triple phase?
Because tumors are better visible in the portal phase, sir.
Which tumor?
Um, if there is any hepatic, like intrahepatic cholangiocarcinoma, if it is, or that might be better visible in the portal phase. So that is the reason we go for a triple phase CT.
That's such a vague answer. See, why do you do a triple phase? Only to identify intrahepatic cholangiocarcinoma, is it?
Hmm.
What all you expect if you later on if you want to treat this patient? What all you want to see in the CT?
I need to look for the lesion first, like what is the site of the lesion,
Okay.
and based on the extension into where it is extending. If it is a mass, whether it's
So
extending
let
into
us
the
be
surrounding.
specific. No, let us talk about this particular patient. Okay.
Okay, so whether it's extending into the hepatic artery, whether it is abutment of the hepatic artery or the portal vein, if it is involving the portal vein, so we can get that based on the CT finding.
What is
And
operability and what is resectability of the tumor?
if the hepatic artery is there is more than 180-degree involvement of the hepatic artery, then the patient is termed as non-operable. However,
Only
if the
only one feature of that, is it? Only one feature
no,
will
sir.
say it is operable or inoperable. So you should categorize. Tell 1, 2, 3, 4 points.
Yes,
Okay.
sir.
These particular points will say that patient is inoperable. So you have to categorize them. Okay. Tell them one by one. Yes.
Uh,
Operability, whether it is operable or not.
if it is involving the confluence and both the bile ducts, if it's a Bismuth called it stage 4 tumor, then that is termed inoperable, sir. And apart from that, if it is involving both the lobes of the liver, then it is termed inoperable, sir. Apart from that, if
We are
there is
talking about this particular patient only. No, why are we going there? You know the findings of the ultrasound. You ask for a CT scan.
yes,
Now why did you ask for a CT scan? To know
to
the lesion
localize
and
the
see if it
pathology.
is operable or not. Yes or no?
Yes, sir.
So talk about this particular patient. Why are we going to confluence?
In this particular patient, sir, the the CT showed dilated CBD and with abrupt cutoff in the distalmost part, and there were loss of fat planes with the medial wall of the D2, and there were multiple enlarged lymph nodes, and the largest of which was 14 millimeters at the porta. And the SMV, and there was involvement of the portal vein, but it was less than 180 degrees abutment of the portal vein. The
Can you show
mass.
me the picture? Can you show us the picture, that
Yes, sir.
particular picture where the portal vein is involved? Just stop at that point where you feel that portal vein is involved. Okay, in this particular picture, can you show us the structures, what you see?
Yes, sir. This is the
Can you trace the portal vein? That's what this thing is. If you can trace the portal vein, you will identify that. Show us the confluence of the portal vein first. Confluence of the portal vein. Those are much lower cuts. No, confluence is higher up. Stop there. Stop there.
Yes, sir.
Where is the portal vein in this picture? Show, point us. Point towards the portal vein. No, don't change anything now. Point towards portal vein. With your pointer, show the portal vein. Which is the portal vein? Just place it on one point and just say this is portal vein.
This one, sir, but
So that is not the portal vein. Sorry. So see, you should also learn reading this. You should not
yes,
depend on the radiologists. Okay. Now, otherwise, how will you know whether it's operable or not? You are the one who is going to operate, right?
yes,
Now,
sir.
if you just depend on what they say, and that's a difficult problem for you. So now, so you what about the report? Did they say that the portal vein is involved?
They said that it was less than 180-degree. I mean, the portal vein was not completely involved. It was less than 180-degree abutment of the portal vein, and the hepatic artery was not involved, sir, mentioned in the report.
So fat plane between the tumor and the portal vein is
D2.
is lost. That's what they said.
Between the yes, sir, fat planes between D2 and fat planes with the portal vein, like mean less than 180-degree. Yes, sir.
Okay. So what do you want to do now?
After this, I would like to go for the staging of the patient, sir. Since I've localized the tumor, I would like to go for the tumor markers, sir. I'd like to send a CA 19.9 if it is elevated or not.
Okay. What do you expect in this case?
You said the USA endoscopic ultrasound has been done in this patient.
Yes, sir.
What is the report of that?
In the US, they could not cannulate beyond the the distal part of the CBD because they could not reach
Sorry.
the tumor.
What did you say? You did try to cannulate. Cannulate.
Yes,
Which
yes,
part?
sir.
Which
The
part?
distal part of the CBD, they mentioned that they could not cannulate the distal part of the
Why do you want to
CBD.
cannulate this patient?
They
Why?
did
What's the
not
reason?
provide.
Sorry.
They did not provide the proper reports, sir, for this
No.
patient.
You tell me. No. Why? Do you want to do when you did a US?
Yes, sir.
Do you want to cannulate this patient? What is the purpose of doing EUS? To understand the lesion, right?
Yes, sir.
Okay. Now, why someone is trying to cannulate the patient then? Would you
But
approve it or not?
no, not for US, sir.
Would you want to do a drainage of this patient, ERCP and drainage of this patient before?
Since the total bilirubin levels are in the range of 18, sir, I would like to
So
drain.
why? What advantage would you get, or what is the issue with that?
It, however, it may lead to more like pre-operative. There might be a chance of increased infection and sepsis.
So you want to drain this before because it's patient doesn't have any fever, it doesn't have any cholangitis. Why do you want to drain? Why do you want to do an ERCP in this patient? Where is the lesion? It's the distal CBD. That's what you said, right?
Yes, sir.
More close to the duodenum.
Yeah.
Hmm?
Yes, sir.
So US, you want to do what is the purpose of US in this patient? You already had a diagnosis. Why do you want to do US in this case?
US can be done to stage the patient based on the findings of the US. The depth of
What?
invasion can be found out, sir, based on the US findings, whether it is involving how much wall of the bile duct is involved, like if it, and we can T-stage the patient based on those findings.
So your management is going to change with that, is it?
No, sir.
Then
Yes.
what is the purpose of doing US? In the CT, you had a doubt about portal vein involvement.
Yes, sir.
So you want to know whether it's really infiltrating the portal vein or not. That could be one reason to do an EUS. Or else, second reason,
First, US was done or CT was done?
CT was done first.
Okay.
probably you can take a biopsy from that needle biopsy.
Yes, sir.
Yes or no? Because the doubt diagnosis is doubtful if you have still doubts about the diagnosis. Yes or no?
Yes, sir.
So I wouldn't encourage anyone to do a ERCP in this patient because he's not in a cholangitis. He's not in a cholangitis. So unless the patient is in fever, has fever, elevated counts, cholangitis, drainage of this particular system is not necessary. Okay. So so what is your conclusion about the diagnosis? Tell us the type, tumor. Tell us what is your management from this point.
Based on this, it is a distal cholangiocarcinoma, and I would like to go for a pancreatic or duodenectomy for this patient because it is in the distal part of the bile duct.
Okay. So what about the portal vein involvement? How are you going to deal with that?
If it is, since in this case it was less than 180 degree and resectable, so we will resect the part of the tumor surrounding the portal vein. And however, if it is involving a great part of the portal vein intraoperatively, then we would proceed with grafting, PTFE graft for the same.
Would you not consider any preoperative neoadjuvant therapy for this patient?
Mm. Neoadjuvant.
What are the criteria for a borderline resectable tumor? Can you name them?
Yes, a borderline resectable tumor is a case in which the portal vein is involved less than portal vein is more than 180-degree involved, and the hepatic artery involvement is abutment is less than 180-degree. In those cases, you can go for a neoadjuvant chemotherapy before proceeding with the operation.
So are you happy with the imaging and do you want to do a PET scan in this patient?
To find out the distant areas, if there is any metastasis, we can go for a PET scan, sir.
So in this particular case, would you want to do it?
Yes, sir.
Why the CT looks fine, no? CT, there's no lesion in the liver. When would you ask for a PET scan?
When we are suspecting that the patient might have distant metastasis, in that case.
So your CA99 comes into play here, right? Okay. If you ask for a tumor marker, CA99. So did you do the test here?
Yes, sir, we did the test and the CA99 was on the higher end of the baseline level, the reference range it was given.
How much?
In this case, it was the CA99 was 15.
399 was the value, is it? CA99 was 399.
No, 15, sir, 15.
15?
Yes, sir.
Just 15?
Yes, sir.
What is the normal value? What's the normal value? It looks like it's less than the normal value. What is the normal range of CA99? 15 is less than normal, no? Isn't it? So then how do you consider that? Obstructive jaundice patient, otherwise also you expect a high CA 99. Okay.
Has your patient undergone US FNAB?
No, sir, they could not. They could not cannulate and reach the mass, so they could not get a biopsy for the patient.
Okay. So by I mean the biopsy findings, I mean histopathological report was not with you.
No, sir.
Okay. So do you can any patient develop cholangitis in absence of stone or malignancy in biliary tree? Do you know any other pathology where patient can present to you with obstructive jaundice, still not having any luminal pathology? Have you heard of I mean primary sclerosing cholangitis?
Yes, sir.
Why this patient is not having primary sclerosing cholangitis?
Multiple fractures are not identified in the.
ಮೊನ್ನೆನೋ ಹೋಗಿದ್ದು ತಾತ ಆ ತರದೇ ಮಾಡ್ತು ನೀನು ಆಡಿದೆ
Multiple. There were no areas of multiple fractures identified in the bile duct for the patient.
On which radiological examination you did not find out the multiple strictures?
In the UHC report, sir, there was the distal, only that was mentioned. Apart from that, the CT finding did not show any additional strictures in the proximal part, sir.
But ultrasonography is suggestive of distal CBD stricture with dilated intrahepatic
Yes.
biliary radicals.
Yes, sir.
So there can be a possibility of sclerosing cholangitis, and I believe MRCP may help.
Yes, sir. MRCP was done. I mean, MRCP, there was MRCP.
Okay.
The MRCP also showed growth in the distal periampullary region and the similar findings as in the CT.
Okay.
What are the other signs of malignancy on MRCP? What is double duct sign? Was there double duct sign in the MRCP of this patient?
No, sir, not in this patient. The main pancreatic duct was not dilated.
Okay. So what was the size of main pancreatic duct?
In this patient, it was 3 mm.
Okay.
So can this mass be non-malignant? Can it be inflammatory mass? Hello.
Yes, sir. Inflammatory mass is less likely because the patient also had a history of significant weight loss that is moving more towards a malignant pathology.
Weight loss per se only, I mean, how can it be pancreatitis in head region leading to a mass
But
formation?
there was no complaint of any epigastric pain or similar to pancreatitis. There was no complaint of pain radiating to the back as is a typical finding in CA head of pancreas, sir.
So that's why, I mean, you need a definitive diagnosis before you proceed for definitive treatment. That can be a possibility. Do you think any other kind of cholangitis can present like this apart from sclerosing cholangitis? some patient of your, I mean, your patient is a 50-year-old male. Can there be other possibility than sclerosing cholangitis? No malignancy, no stone. Obese patient.
There can be a benign stricture.
Benign structure. But what can be the etiology? So there is a autoimmune cholangitis. Though it is and it is becoming quite I mean, detected very commonly now onwards.
Okay.
So you must keep a, I mean, a differential diagnosis like this.
Yes.
So the more important question is, if there is a periampullary mass or mass in the distal CBD, the histopathological or biopsy diagnosis is indicated before you go for any definitive management like pancreatic or duodenectomy.
Yes, yeah, that is what I want to convey. Yeah.
That is why I'm asking. The traditional teaching said that it's a radiological diagnosis. You can carry on with the pancreatic or duodenectomy. But in the recent era, when you have all the investigations, all the modalities like endoscopic ultrasound, you can go for, you must confirm the histopathologically, then only proceed for procedure, depth procedure.
Okay, so what's your plan now? You have this, you want to do a US and then do biopsy, or you want to go and resect it?
I would like to go for a US guided biopsy, sir. And based on the report, if it is proven malignant, then I would like to proceed with the definitive resection.
So what are the ways you deal with the portal vein here? So you already had infiltration. You said one method is to put a graft. What are various options you have to deal with that lesion involving the portal vein?
And if
Sir
it
had
is
already asked you why don't you go for neoadjuvant chemo?
borderline resectable, then we can go for neoadjuvant chemo, sir. Yes.
So what is the challenge for you to do neoadjuvant chemo? In this particular case, what is the challenge for you to give neoadjuvant chemo? Or else you'll just start it tomorrow?
No, sir, we need to also look for the nutritional status of the patient.
He's well preserved. You told us, we know that he's well preserved. What else?
Yeah. And there might be some complications due to the stasis. There might be some bleeding episodes, or
So tomorrow morning, you would want to start him on neoadjuvant therapy?
Yeah.
What will prevent you, or are you okay to go ahead?
Would you like to optimize the patient for the NSCT?
Yes, sir.
What optimization? What are you thinking about?
Firstly, the nutritional status, which in this
Nutrition is good.
patient
We know
was
nutrition is good. I'm not worried about nutrition. Next.
Jaundice.
He's an icteric patient. He's a jaundice patient. Would you want to start him on chemotherapy immediately?
If
Is it okay?
No, sir, we would like to reduce if possible, but in this case, the mass which would not allow the
Yeah, so the mass could not be allowed, did not allow you to do ERCP, but there are other modalities to decrease. No, if you want to start him on chemo radiation, I mean neoadjuvant.
we can go for a percutaneous transhepatic.
So first of all, if you want to give a neoadjuvant, his bilirubin should be less than 2, right? 3, in fact, 2 or 3.
Yes.
So unless you decrease the bilirubin levels to that level, you're not supposed to start him on neoadjuvant chemotherapy. So that's a challenge for you. So how do you want to do it is a different story. Okay. Okay. I think so. You didn't answer that one question for me. What are other possibilities to reconstruct that portal vein, or what are the ways you can remove the tumor from the portal? That is the crux of the problem, no? So you have something involved there. You want to go ahead and do the procedure. So how do you going to deal with it is the question.
We can go for primary repair if the defect is small in the SMV after removing the
How
tumor.
much? What do you mean by small? What length?
Then, not sure, less than 2 centimeter, I'm not sure, sir.
Sorry?
Less than 1 centimeter if the defect is, then we can go for a primary repair.
Okay.
If it is more, more than 1 centimeter, then we can go for a graft placement.
What grafts?
Interposition grafts, we can go for a jugular venous graft or a femoral venous graft.
Vein patch? Vein patch is a possibility. Vein patch.
Like, I'm not sure, sir, but
Okay. So what are the challenges you expect in case of when you proceed to do a Whipple's apart from the portal vein in this particular patient? Other challenges. What about the pancreatic duct?
the pancreatic duct in this particular patient was not dilated.
It's
So,
3 mm, you said.
yes, sir. Yeah.
So what are the challenges for you to do that? So small duct, what are you anticipating?
Like, we can go for a like pancreatico gastrostomy because the duct was small in this case.
What are the ways to deal a small duct? Pancreatic jejunostomy, pancreatic gastrostomy. What else you can think about?
Distal pancreatectomy, but
Distal pancreatectomy.
no, but not in liver.
Why? Why distal pancreatectomy? What are you talking? What do you mean by distal pancreatectomy?
Not in this case, sir.
No, which case you will do that?
So,
In any case, you are not going to do. Sir is asking very specific question that you are doing a pancreatic duodenectomy and pancreatic duct is 3 millimeter. So what are the different options? Surgically, if you are doing pancreatic jejunostomy, what are the different methods you know, and particularly for the smaller ducts? Was this patient operated?
Yes, sir.
What was done?
In this case, pancreaticoduodenectomy along with pancreaticogastrostomy and hepaticojejunostomy and gastrojejunostomy.
Okay. So you have to do pancreaticojejunostomy. What are the different options?
So was portal vein involved when you operated?
Yes, sir. No, sir. On operation, the tumor mass was very close to the portal vein, but it was not like abutting the portal vein. So we could resect the mass by leaving the portal vein intact.
Okay.
Which arteries you ligated?
The gastroduodenal artery, sir,
And
and the superior and inferior pancreaticoduodenal artery.
so you ligated superior and inferior pancreaticoduodenal, I mean, separately?
At the upper and the lower part of the pancreas.
Okay. Okay.
Since we were discussing about the portal vein, I would like to ask Dr. Vaibhav, what is your experience of this portal vein involvement?
Portal vein involvement, actually, we don't do portal vein resection if the mass is involving portal vein more than 2 centimeter. Then we refer that patient to a more experienced center. But up to 2 centimeter, we can mobilize the portal vein and superior mesenteric vein, and end-to-end anastomosis can be carried out with, that is possible. But if it is more than 2 centimeter, we don't touch. And as a principle, if tumor is more than 4 centimeter, then also we don't touch the tumor. After downstaging, after neoadjuvant therapy, if the size is not coming down below 4 centimeter and it is close to, uncinate process involvement, then we don't touch that tumor. Then again, also we refer it to the more experienced center.
Thank you.
I had an experience of doing 3 surgeries with portal vein resections. In one case, we could only shave it off by doing a sleeve, like, partial excision of the portal vein.
Okay.
In one case, like Dr. Vaibhav said, we could, when the gap between the two ends of portal vein is less, about 1 to 2 centimeters, we can mobilize it and then also do end-to-end anastomosis, which I could do in one patient.
Yes.
And one patient, we removed the vein from the neck and then did a primary, graft.
Patch or
Graft. The
graft?
defect.
Okay.
So we had to use the graft.
Okay.
We never use. I
Great.
never used other than patches other than the graft, natural vein. So
Okay. Great.
Yes. Great. Yeah.
Khanna sir.
Kanagwel sir is there?
Kanagwel sir. Khanna
Sir,
sir.
yes, sir. Yes, sir. Sir, normally we allow the candidate to ask any doubts to be clarified.
Yeah.
Indranil, do you have any doubts to be clarified?
Yes,
So
sir.
let me conclude first before Indranil speaks. Indranil, I think you were a little biased to start with. You already
Yeah.
had your diagnosis in your mind, so you kept on saying distal, whereas all your findings were, on the contrary, they were not supporting your, diagnosis. First thing, okay. Number two, you should be very categorical in asking your investigations. The investigations are again done in 3 folds. First, one to confirm the diagnosis. Second, to prepare the patient, stage the disease, and then third, to prepare the patient for the surgery or any therapy. So you should always answer your diagnosis or your investigations in that order. So it will be more clear for the listeners also, and they will understand what is the clarity you have regarding the approach to that particular problem. Okay. And third thing is, you should be very clear in your understanding about CT scan findings. You should also have a habit of looking into your CT scans, no, not just depend on the reports. Okay. Reports can be very, very deceiving. So if you can really follow the CT scan, you can decide on whether this patient is really operable or not. No. And also when you mention, don't conceal anything from the
Yes.
examiners. You should always show all your findings here. Please, whatever findings you have, you should conceal. You should not conceal from the examiners. When they ask for a report, you should show the complete report, not the ones which you want to highlight. Okay.
Yes.
Yeah, this is my observations. I think other examiners can tell their observations.
No, you did very well. But the most important part was that only you should not get biased what patient is having. Whenever examiner is asking, you should always keep your options open, right? It was not a clear-cut case. You should always, whenever you are in doubt, you always put a differential diagnosis and put the first diagnosis which is most likely. And then you can ask the examiner that I would like to confirm by the investigations, right? Otherwise, you did well.
Yeah, it was nice. I think even in your history part, the negative history was so specific. I mean, you were talking only in one direction. So I think I agree with all seniors that you should not get biased right from the beginning. You should present a case and have differential diagnosis. But
Okay.
otherwise, it was a good presentation. Yeah, nice
Yeah.
presentation.
Thank you.
So you
Thank
may
you, sir.
ask your questions, Idril.
Indrajit,
I had
do
a
you have
doubt.
any doubts? Yeah, please ask.
Yes, regarding the pancreatic duct that you were saying, what are the challenges? I wanted to ask about that, sir.
So whenever there is the small duct and the duct and the gland is so soft, like in this particular case, the leak rates are very high. Leak rates are very high, and handling the gland will be a difficult task because your sutures will be cutting through, and that will be a problem. First thing, and also when the duct is so thin, so small, stricture rates also can be higher. So if you want to do, I mean, at our center we still practice duct to mucosal anastomosis only. So we use loops and then do 6O sutures, to do the anastomosis. So that's how I do. So there are other centers where they do dunking.
Yes.
Dunking is inserting the pancreas into the jejunum or into the stomach and doing a mass ligature, like anastomosis. So that is also a possibility. So the leak rates are higher, the stricture rates are higher, and the anastomotic disruption rates are higher when the ducts are small and the gland is so soft. So this is one of the most difficult scenarios for any pancreatic surgeon to operate upon. Okay. So that is the reason why I was insisting on for you to understand these things.
Thank you, sir.
And when duct is small, one thing I will like to add to sir's explanation, that what we do is we take pancreatic parenchyma to serosa suture with the jejunum, and then we take 6 everting sutures of pancreatic duct. So that may help in approximating the duct to mucosa very precisely.
Yeah.
I mean, every interrupted, and then we may place a small infant feeding tube or so as a stent also. We do, and we fix the inner, I mean, with proline, we fix that stent. So it helps in sustaining the, but yeah, when the pancreas gland is soft and duct is small, it is a difficult situation. Very difficult situation.
So
Thank you, sir.
one other
And
technique
we
we
must
do
use
when
loop.
the
I
gland
do
is
agree
so,
with, yeah.
yeah, one other technique we do when the gland is so soft is just give a shot of octreotide
Yeah.
just before doing the anastomosis. That will make the gland little stiffer.
Yeah, no,
Will help us in holding the sutures. That's one
Yes.
technique which we follow. Luckily, we didn't have many troubles doing it so far. But centers which do these procedures in high volumes, they very commonly encounter such situations. So that is one of the Achilles heel. We say Achilles heel of a pancreatic duodenectomy surgery. Yeah.
So that is why MRCP is very important to know the duct size, right?
Yes.
And one thing I will like to add is before you plan pancreatic duodenectomy, you have to make sure the any variations of hepatic arterial anatomy. If there is any anomalous vessel coming from SMA, right accessory or replace, that you have to keep in mind before you proceed. This is just a additional point.
So it's
Thank you,
always
sir.
better to get a triphasic CT instead of just a contrast enhanced CT, because like Dr. Weber said, all the anatomical variations, involvement of the tumor in relation to the artery and veins, and also periportal lymphadenopathies, all these things, if you can understand better, you can plan your surgery better, and then definitely that will help in improving your outcomes.
Yes.
Thank you, sir.
Thank you very much, Indranil and other faculty. With your permission, we move on to the next case. I think today we have all gastroenterologists. Next case was supposed to be portal hypertension, and for some reasons the candidate could not be here. So portal hypertension case is shifted for the next day. So we have a case of varicose veins to be discussed. I'm sure if you have interest, you are welcome to stay back, but I will not pressurize you. Thank you for joining today.
Thank you, sir. Thank you.
Thank you. Thank you, sir. Yeah.
Thank you, sir. Thank you very much for taking time off to help us out. Thank you very much.
Thanks.
Kamran, please introduce yourself and start your presentation.
Yep, sure, sir.
Kiran, sir, please take over, sir. Thank you.
Yes, sir.
Started with thank you, da. Go to the first slide.
Yes, sir. Just give me a minute, sir.
Prepared.
Yes, sir. A very good evening to one and all, sir. So I'm Dr. Kamaran, third year postgraduate from Government Stanley Medical College. So my guides are HOD Professor Dr. A. Anandi Madam and Chief Professor Dr. T. Bob Anthony, sir. So today I'm going to present a case of varicose veins. Shall I start, sir?
Yes, please.
So my patient is a 52-year-old gentleman, Mr. Anandan, a cook by occupation, hailing from Tiruvallur, presented to the OPD with chief complaints of dilated veins over the right lower limb for the past 3 years. He also has pain in the right lower limb for the past 3 months. History of presenting illness, the patient was apparently normal about 3 years back, after which he presented with complaints of dilated veins in the right lower limb for the past 3 years, which was insidious in onset. Initially started in the right leg above the ankle. Now it has progressed up to the mid-thigh region. It is aggravated by walking and on prolonged standing. It is relieved by rest and limb elevation. History of pain over the right leg for the past 3 months, which is dull-aching type of pain, intermittent, and it is aggravated by prolonged standing and walking, relieved by lying down and on resting. He also has history of itching over the medial aspect of right lower leg for the past 3 months, history of hyperpigmentation around the ankle joint for the past 3 months, history of prolonged standing 8 to 10 hours per day for the past 25 years, no history of leg swelling, no history of bleeding, no history of ulcer, fever, no history of difficulty in walking, no history of prolonged immobilization, no history of trauma, no history of abdominal distension, chronic constipation, no history of breathlessness. So past history, the patient does not have a history of similar complaints in the past. He's not a known case of type 2 diabetes mellitus, systemic hypertension, COPD, CAD, or seizures. No history of previous hospitalization or prolonged immobilization. No history of previous major surgeries. Personal history, the patient consumes a mixed diet. He is not a smoker. No history of alcohol consumption. The patient has normal bowel and bladder habits. No significant family history. So summarizing with the history, my patient is a 52-year-old gentleman, cook by occupation, with history of prolonged standing. can be complaints of dilated veins along the medial aspect of right leg and thigh for the past 3 years, associated with a dull aching pain for the past 3 months, which is aggravated on prolonged standing and walking and relieved by rest and limb elevation. The patient also has history of itching and hyperpigmentation. He has no history of ulcer, no significant past history. This is likely a case of symptomatic varicose veins involving the right lower limb.
You can please go to first slide.
Yes, sir.
Amaran, what are the risk factors in your patient?
Sir, my patient has history of prolonged standing, sir. He stands for almost 8 to 10 hours per day for the past 25 years.
Okay.
So that is a very major risk factor for developing varicose veins in my patient, sir.
Okay. What are the other risk factors apart from prolonged standing?
Sir,
What are the
apart
other
from
risk factors
prolonged,
for the varicose veins?
sir, in case of secondary varicose veins, if the patient had any previous history of deep venous thrombosis or prolonged immobilization, it can be secondary to DVT, sir.
But tell what are the causes of the secondary varicose veins?
Sir, causes of secondary varicose veins, it can be either due to increased intra-abdominal pressure, like abdominopelvic tumors. In case of females, the female might have a giant fibroid or ovarian cyst, which compresses the venous outflow, which indirectly results in varicose veins. They might also have iliac vein thrombosis, which again can lead to varicose veins. Some congenital causes, like Klippel-Trenaunay syndrome, the patient might have varicose veins.
What is the normal physiological cause for the varicose veins?
Sir, pregnancy is one of the physiological causes for varicose veins. The gravid uterus compresses the major veins in the abdomen and pelvis, which results in varicose veins.
Okay. So your patient is of a primary varicose vein or it's a secondary varicose vein?
My patient is likely to have a primary varicose veins. He does not give any history regarding the etiological factors that contribute for a secondary varicose veins, sir.
Okay. Can you go to the next slide? Why is having the pain?
Sir, pain might be due to the dependent pooling of the blood in lower limb veins, which ultimately cause stretching of the veins, and the patient might have pain towards the end of the day or when he stands for a prolonged period of time or after walking. Pain might be also present in a patient with the association of DVT. In that case, the patient will have bursting type of pain, especially in the calf region, sir. The pain might be also contributed by the tissue hypoxia, which is ultimately sequel of chronic venous insufficiency.
Can any inflammation can cause that?
Sorry, sir.
Any inflammation of the veins can cause the pain?
Yes, sir. Any associated superficial thrombophlebitis,
Yes.
the patient might also have pain along the course of the vein, sir.
Right. Next slide.
Yes, sir.
Do you know what is venous claudication?
Sir, venous claudication occurs in a patient with deep venous obstruction. So, for compensating the venous return, the patient develops multiple collateral vein channels. So, these collateral vein channels are usually able to compensate for the obstructed deep venous system at rest or mild exercise. But when the patient is exercising out of proportion, the collaterals are not able to carry the venous return. So the patient might develop pain when he's exercising too much, sir. and this pain is not promptly relieved by rest, as in arterial claudication pain. The patient might need to rest for some time and then put his limb into elevation. And then after some time, the patient might get some relief from the pain.
What is the neurogenic claudication?
Sir, neurogenic claudication, the patient will develop pain as soon as he takes the first step. So this type of pain is relieved when the patient exerts some type of posture in which the pressure on the nerve is relieved, sir.
Go to the next slide. Why there is itching?
Sir, due to chronic venous hypertension, as in this case, the patient is saying he is having varicose veins for 3 years. Due to chronic venous pooling, there occurs chronic venous insufficiency, and the patient might develop eczema as a complication of this varicose veins. So he's having itching.
Dermatitis?
Sorry, sir.
Dermatitis?
Yes, sir. Dermatitis.
Yes.
Yes, sir. Dermatitis along with itching and redness over the affected area. So the patient is having itching, sir.
Why there is hyperpigmentation?
So hyperpigmentation is due to hemosiderin deposition in the tissues. When there occurs chronic venous pooling, there occurs capillary damage and the RBCs break down, and then hemoglobin is getting released and is converted into hemosiderin. So this hemosiderin deposition around the tissues can cause hyperpigmentation, sir.
Why it is around the ankle region? What is that area called as?
Sir, this is more common in gaiters area. Gaiters area is the lower 1/3 of the leg, especially in the medial aspect of the lower 1/3 of leg, which is prone for chronic signs and symptoms of chronic venous insufficiency because of so many perforators are present around this joint, and it is more prone for getting the signs and symptoms of chronic venous insufficiency.
Which is the longest vein in the body?
Sir, great saphenous vein is the longest vein in the body.
Why do you get the venous ulcer on the medial side mainly?
Sir,
You get the venous ulcer most of the time. It's on the medial side of the ankle joint.
yes, sir.
What is the reason for that?
Sir, most of the perforators of the leg are located around the gaiters area, especially in the medial aspect.
Yes.
And the pressure is also higher when compared to other parts of the leg. It is much higher in this region. So the patient is more likely to develop an ulcer in the medial aspect rather than the lateral aspects.
And there is almost no muscle in that area. And it is just
Yes, sir.
underneath the skin is the periosteal area is there.
Yes, sir.
That is more common in the lower part of on the medial side.
Yes, sir.
Okay. Go to the next slide. Now, if there is bleeding from the varicose vein is there, what should be done? Immediate treatment?
Sir, we should compress the bleeding site and elevate the limb, sir. Most of the times it is able to settle on its own. If at all, if the bleeding is not settling, we have to intervene, sir. But most of the times it is just compression and elevation of the limb, sir.
Okay. Next slide. Is the family history makes any difference? Family history, does it run in the families?
Sir, no, no, sir.
No, it runs in families, you know.
Okay,
Varicose veins, they run in family.
yes.
You know what is the incidence of the varicose veins in the general population?
Sir,
Any idea what?
around 30 to 40% of the population have varicose veins, but most of them are asymptomatic.
Yes. But almost about half of the population, they have got the varicose veins.
Yes.
What is ambulatory venous hypertension?
Sir, normally the blood in the lower limbs is getting pumped higher into the central venous system by three mechanisms. One is due to the pumping mechanism of the thigh, calf, and the foot, and then due to intrathoracic pressure that becomes negative during inspiration, there is venous return, and the other is the push mechanism exerted by the arterial system. So when normally the venous pressure at the lower end of the leg is around 80 to 100 mm of Hg in standing position. So when the patient is walking, the calf pressure rises to 200 to 300 millimeters of mercury. This increase in calf pressure pushes the blood from superficial venous system into the deep venous system. And when the calf muscle is getting relaxed, the blood from the superficial venous system is getting pulled into the deep venous system, and there is a fall in the superficial venous system pressure from 100 to around 30, sir. But when the valves are incompetent, when the perforators are incompetent, this mechanism does not happen, and the pressure in the superficial venous system does not fall to 30, which is normal, and then it remains high, and the blood is not getting emptied into the deep venous system. So when the patient ambulates, the pressure does not fall in the superficial venous system. This is known as ambulatory venous hypertension, sir.
Okay. How does that correlate clinically if there is a increased ambulatory venous pressure is there?
Sir, it is demonstrated by a modified Perthes test, sir.
What pathology will occur in a patient who has got an increased ambulatory venous pressure?
Sir.
They are more likely to develop the venous ulceration.
Yes, sir.
Okay, so the C6 disease which is there,
yes, sir,
is more common with the higher ambulatory venous pressure there.
Yes, sir.
Okay. Go to your next slide. Anybody wants to ask any question? Dr. Parmar?
No, sir, we can continue.
Okay. You can go on the examination now.
Yes, sir. So moving on to examination, general examination. After getting consent, the patient was examined in a well-lit room with adequate exposure below the umbilicus in standing and lying position. The patient is conscious-oriented, afebrile, hydration fair, well-built and well-nourished, no pallor icterus, clubbing cyanosis, no generalized lymphadenopathy or pedal edema. The vital signs are stable, pulse rate 85 per minute, blood pressure is 120/80 mmHg, respiratory rate is 16 per minute, saturation in room air is 99%. So examination of the right lower limb. On inspection, attitude of the limb remains neutral. No visible discrepancy in size when compared with the contralateral limb. No visible deformity. Dilated and tortuous veins over the medial aspect of the right lower limb from ankle till mid-thigh. No dilated veins along the posterior or lateral aspects of the lower limb. Hyperpigmentation of the skin noted over the medial aspect of lower one-third of the ankle. No ankle or leg edema, no redness, no ulcer, no scar, no lipodermatosclerosis, no malleolar hair, no visible cough impulse seen at saphenous opening. The gait of the patient is normal, no loss of hair, no brittleness of nails. So this is the clinical picture of my patient. So moving on to palpation, the inspectory findings are confirmed. Palpable dilated veins present along the course of the great saphenous system up to mid-thigh. No local warmth or tenderness, no thickening of veins, no thickening of skin. Sorry, sir, I forgot to add no pitting edema in this patient. Modified Perthes test, dilated veins present, but there was no pain, which suggests the patient does not have a deep venous thrombosis. Brody Trendelenburg's test 1 positive, SFJ incompetence is present. Trendelenburg's test 2 positive, perforator incompetence is present. Morris's cough impulse felt in the saphenous opening. Multiple tourniquet test positive at above knee and below the knee indicates perforators incompetence. Pratt's test, bulging of perforators noted above and below knee. Fegan's test, multiple defects noted in the deep fascia along the axis of the dilated veins. Percussion, Schwartz test positive. On auscultation, no bruit or venous infarct. Examination of the left lower limb, normal, no dilated veins. So, neuromotor examination and arterial pulse examination of both the limbs. Sensation remain intact in both the lower limbs. No discrepancy in mid-thigh and mid-calf bulk between both the lower limbs. Range of movements is full in both the lower limbs. All peripheral arterial pulses are palpable in both the lower limbs. Other system examination, CVSS1 is to heard, no murmur. RS is normal. Per abdomen, soft bowel sounds heard, no tenderness, no palpable mass in the abdomen. CNS, no focal neurological deficit. Summarizing, a 52-year-old gentleman cooked by occupation came with complaints of dilated veins along the middle aspect of the right leg and thigh for the past 3 years, associated with dull aching pain for the past 3 months, which is aggravated on prolonged standing and walking and relieved by resting and limb elevation. The patient also has history of itching and hyperpigmentation. There is no significant past history. On examination, there is dilated and tortuous pains along the middle aspect of right leg and thigh. There is associated hyperpigmentation around right lower one-third of leg. Trendelenburg's test 1 and 2 were positive. Multiple tourniquet test was positive above and below knee. There is no ulcer. So my diagnosis for this patient is right lower limb primary varicose veins with saphenofemoral junction incompetence and incompetence of above and below knee perforators. The C classification comes out to be C symptomatic 4A, EP A superficial plus perforator, and P is the reflexor. Sorry, I forgot to add that.
Okay. Can you go to the special test which you have done? Go to that slide.
Yes, sir.
Yeah. Go on telling about what did you do in the modified Perthes test.
Sir, in modified Perthes tests, we identify for every other test, we have to empty the veins by milking of the veins. For this modified Perthes test, we don't do that. We just identify the saphenous opening and then we tie a tourniquet just below the saphenofemoral junction. And then we ask the patient to ambulate for 1 minute, sir. If there is any presence of deep venous thrombosis, the patient will feel bursting type of pain in his calf, which is a subjective response, and then we will be able to observe the engorgement of previously existing varicosities, sir, which indicates that the patient is likely having a DVT.
Okay. Yeah. Brody Trendelenburg 1 and 2. How did
Sir,
you do that?
in Trendelenburg's test 1, we make the patient lie down flat and then elevate his limb and milk the veins and empty it, identify the saphenofemoral junction, and then tie a tourniquet just below it. And then we ask the patient to stand up, and then we observe for any rapid filling. I'm sorry, we observe for any gradual filling of the veins from below downwards, which indicate this is more of a inference of a test 2. By this, we can infer that the patient is having perforator incompetence. If at all he does not develop any gradual venous filling from below downwards, we release the tourniquet above, and then there occurs rapid retrograde filling of the great saphenous vein from above downwards. This indicates the patient is having a saphenofemoral junction incompetence, sir.
Okay. Morrissey cough
What
impulse.
time?
Sir, Morris's cough impulse, we again make the patient lie down and then we ask the patient to cough and then observe at the saphenous opening area for any appearance of any swelling, which indicates the patient might have a saphenofemoral junction incompetence again, sir.
In which case the Morrissey cough impulse is positive.
So, the patients who have subphena varix
Okay.
will have a Morris's cough impulse positive, sir.
Yes, we will get a, there will be vague swelling in the saphenous region. So what is the differential diagnosis of that saphenopharynx?
Sir,
Where you can get the cough impulse, yeah.
Sir, femoral hernia can be one of the differential diagnosis. In which case the femoral hernia will be more medial than the saphenopharynx, sir. Also in saphenopharynx, the patient will be having associated dilatation of veins over the thigh and leg regions, sir. In case of a femoral hernia, the patient most likely will not have a varicose veins.
Any other varix can be there apart from the saphenopharynx?
Sir, patient can also have lymphovarix, sir.
Lymphovarix, good. Okay, multiple tourniquet test.
Sir, multiple tourniquet test
How many
is done.
tourniquet you applied?
Sir, 4 tourniquets, sir. One above the ankle, below knee, above knee, and one just below the saphenous opening, sir. And then we remove the tourniquet from below upwards, sir. If the dilatation of veins is seen above the tourniquet, that region has a perforator incompetence, sir.
Red test?
Sir, Pratt's test, we tie and we ask the patient to lie down, empty the veins, and then we tie an S-mark bandage from below downwards until the saphenous opening, and then we tie a tourniquet just below the saphenous opening, and then we remove the S-mark bandage to look for any blowouts along the blowouts in the lower limb, which indicates the corresponding blowouts areas have a perforator incompetence, which is again confirmed by Fegan's test by running our fingers along the venous pathway. We can feel defect in the deep fascia, sir.
Do you have the Ashmar bandage with you?
So, no, sir. We simply tie a crib bandage, sir, in practice.
So you have to, in fact, apply the Ashmar bandage, not the simple that one. Okay.
Okay, sir.
To demonstrate that, yeah. Okay. Now, Parmar, please, can ask.
Yes, sir. The next slide, please.
Yes, sir.
Next slide.
Yes, sir.
Okay. So what is difference between venous ulcer and varicose ulcer?
Sir, a varicose ulcer is primarily due to a solely dilated superficial venous system, whereas a venous ulcer can be a stasis sequel wherein the patient previously had one venous occlusion in the deep venous system, and the patient subsequently has developed this ulcer, sir. The stasis sequel is more prominent in a venous ulcer. The patient will have hyperpigmentation, itching, and then redness along with the ulcer, sir. These signs and symptoms are more pronounced in venous ulcer than in varicose.
The next slide, please.
Yes, sir.
Next slide. Okay. So there are how many percentage of the patients can have unilateral and bilateral varicose vein, which is common? Unilateral or bilateral?
Unilateral varicose veins are more common.
Unilateral is very common. If it is a bilateral, then what is the significance of that?
Sir, if the patient is having a bilateral varicose veins, we should probably rule out any abdominopelvic causes that is responsible for secondary varicose veins. Any midline.
Yes, yes. So, sir initially said that causes of secondary varicose vein you must
Yes,
rule
sir.
out whenever there is a bilateral varicose vein. Okay, so
Yes,
now
sir.
how will you proceed further? How will you manage this case? I think Khanna
Yes,
sir, we
sir.
can start with this, right, sir?
Is it more common on left side or right side?
Sir, varicose veins more common on the left lower limb, sir.
The reason for that? Why it is more common on the left side?
I'm not sure, sir.
Especially it is because of the secondary type of the varicose veins which are there. Okay, because of the compression of the iliac veins by the iliac artery.
Yes,
What
sir.
is that called as?
Sir, May-Turner-Cockett syndrome, sir.
Yeah, May-Turner-Cockett. No? So mainly because of that reason, it is more common on the left side
Yes.
as compared to the right side.
Yes,
Now,
sir.
this SEEP classification which you are given,
Yes, sir.
what is 4A?
Sir, 4 is when the patient is having eczema, sir.
Does your patient has the eczema?
Yes, sir. But the patient is having hyperpigmentation, and then he also has itching.
Okay. Mhm.
Yes, sir.
What is 4C?
Sir, 4C is coronophlebectasia, sir. Fan-shaped pattern of telangiectasia reticular vessels present over the medial malleolar region, sir.
So what is the significance of that 4C? Corona?
So, so that is the patient is already having an advanced venous disease.
Initially, in the last SEEP classification, where
Sir.
was this one, corona?
Sorry.
Corona was in the C1.
Okay, sir.
It means it is a very initial phase. But
Yes,
then
sir.
it was found that it is not a spider veins or the reticular veins which are there, but it is a advanced disease where there is very high chance of having the ulceration. That is why this corona came into the 4C.
Yes, sir.
Okay, yeah. Okay, go to the next slide. So your diagnosis is here, and there is no differential diagnosis as well. There is no differential diagnosis, or you want to give any differential diagnosis?
Sir. No, sir. I'll go with varicose veins.
Yeah, okay. So how you are going to go ahead?
Sir, yes, sir. I'll proceed with the basic investigation file. First of all, I'll confirm
Did you look for the ABPI in your patient? Have you looked for ABPI in your patient?
Sir, no, sir.
Do you think it should be done?
Sir, ABPA, yes, sir, should be done in patients with venous disease to rule out arterial insufficiency, sir, which can often coincide.
So you should always do the ABPI, in
Yes,
all
sir.
the cases of varicose veins, because the treatment
sir.
may also differ
Yes, sir.
depending on the ABPI. What is
Yes,
the
sir.
normal ABPI?
Sir, more than 0.9, sir.
Up to?
Up to 1.3, it can be up to 1.3, sir.
If it is more than 1.3, what does that mean?
Sir, if it is more than 1.3, it indicates calcification of the arterial walls, sir. Arteriosclerosis can be present, sir.
So if the atherosclerosis is there, that
Yes,
is
sir.
more likely to be the higher ABPI.
Yes, sir.
Okay. So you've done the duplex ultrasound in your patient. What do you
Yes, sir.
understand with duplex?
Sir, duplex ultrasound is a combination of B mode ultrasonogram plus Doppler ultrasonogram, sir.
Okay. So what you want to see by the B mode and what you want to see by the Doppler?
B mode ultrasound is the grayscale imaging that we see, sir. We see the anatomy of the veins, sir. Whereas Doppler ultrasonogram is mainly for the to identify the normal flow and reflex, if any present, sir. Mainly to understand the flow and reflex of the venous system, sir, function of the venous system, sir.
So what are the things you want to see on duplex ultrasound in the case of varicose vein?
Sir, we have to mainly see the patency of the deep venous system, if there is any DVT present or not, sir. We look for any reflex that is present in the SFJ, SPJ, and perforator, sir. And then if the reflex is present, we have to grade the reflex, sir. And we'll also look for any complications like thrombophlebitis associated with varicose veins. We can also look for any uh, secondary causes that attributes to this varicose veins, sir.
So when do you say that the saphenofemoral junction is incompetent?
Sir, the patient is asked to stand, and then the ultrasound probe is kept over the saphenofemoral junction area, sir. Uh, we ask the patient to do a Valsalva maneuver, or we gently compress the calf area of the affected limb, sir. Um, this creates an augmented flow in the saphenofemoral junction area, which is normally heard as a whoosh sound in Doppler, sir. We can see the flow as a bluish flow in the monitor. If the SFJ is incompetent, there is a reflex of the forwardly pushed blood back into the saphenous vein, sir. So this is indicated by color change from blue to red, sir.
But when do you say it is incompetent?
So normally the reflex can be present up to 0.5 seconds, sir. If it
0.5
is
seconds,
more than
it is
0.5
more than
seconds,
0.5 seconds, then you say it is incompetent.
yes, sir.
Okay. Right. And how do you say there is a perforator incompetence is there? If it is more than 0.3 seconds is there, and the defect in the deep fascia is more than 3 millimeters in size, then you
Yes,
say
sir.
that particular perforator is incompetent.
Yes, sir.
Okay. So more than 0.3 seconds and 3 millimeter defect in the deep fascia there.
Yes, sir.
Do you
What
measure
is the
the
import?
diameter? Yeah, please. Yeah, carry on.
That was also all I was asking. What is the importance of diameter of saphenofemoral junction and the great saphenous vein diameter?
Sir, it helps in determining the modality of treatment which we are going to choose, sir. If it is a very grossly dilated vein, more than 2 centimeters,
Saphenofemoral junction up to what is considered normal size?
up to 5 millimeters.
Up to 5 to 5.5 millimeter, it is considered normal. If it is more than that,
Sir, sir,
then
if
it
it
is
is more than
significant.
sir.
How it is significant? If diameter is 7 millimeter and diameter is 12 millimeter, what change it will make? What is the importance? So you should always look for the saphenofemoral junction diameter.
Yes, sir.
First, to confirm the reflux. Second, to for the management point of view.
Yes, sir.
Right?
Yes, sir.
Sir, you were asking something.
Yeah.
Khanna sir.
Nagaran,
Yes, sir.
how do you define the varicose veins?
Sir, varicose veins are dilated, elongated, and tortuous superficial veins which are more than 3 millimeter in size with a demonstrable reflexor.
Okay. Now tell, if you want to measure the GSV diameter. Which is the best place to measure the GSV diameter?
Sir, usually we take mid-thigh level.
Okay, in the mid thighs, you know, you take the level of that. Yeah. Okay. So, what was the finding in your patient?
Sir, yes, sir. So Doppler of my patient, right lower limb, superficial venous system. The great saphenous vein measures to be 8 millimeter in diameter, to be incompetent with the grade 2 reflex. The short saphenous vein measures 4 millimeter in diameter with a competent saphenopopliteal junction with no reflex. Two incompetent perforators noted, one above the knee and one below the knee along the medial aspect. The deep venous system is found to be patent, no evidence of DVT. Arterial system, triphasic flow pulsatile. Left lower limb normal study, sir.
What is the inference?
Sir, my patient is having right lower limb varicose veins with saphenofemoral junction incompetence and perforator incompetence above and below the knee, sir. With the patent deep venous system.
Deep veins are normal.
Yes, sir. Deep venous system normal, so no evidence of DVT.
Okay. So, what else you want to do? Any other investigations for this patient?
Sir, other basic investigations that we usually do for a preoperative assessment, sir.
Okay. In
So
case if the deep veins are not
sir.
patent, then
Yes,
what
sir.
other investigations can be done?
The deep veins are not patent. A venogram can be ascending or descending venogram can be done, sir.
Okay. Venogram can be done. Anything else? Any other, just for sake of,
Echocardiography can do.
no, in the limb? What are the other things which can be done? It is not the practical one, just for the investigation's sake, I'm asking. Otherwise, the duplex is the one only investigation.
Sorry, sir.
Plethysmography?
Okay.
Plethysmography can be done. You can measure
Yes,
the
sir.
ambulatory venous pressure.
Yes, sir.
You can use the colloid studies.
Yes.
What is IVUS?
Sir.
It is intravascular ultrasound.
Okay, sir.
Yes, in the cases of the deep veins problem which is there,
Yes,
or the
sir.
patient where the recurrent problem is there, then in those cases you can go for the IVUS studies.
Yes, sir.
Okay. So based on this, you will do the routine investigations and you find everything is normal. So what
Yes,
are
sir.
your plans now?
Sir, we can proceed with the radio frequency ablation for this patient, sir. Since
Okay,
it's minimally
both the superficial veins are dilated and incompetent, you know?
Sir, we can
SPJ
again
is competent. Okay. SPJ is competent, no reflux.
Yes, sir.
GSV, SFJ is incompetent. Okay.
Yes, sir.
What are you going to do?
So radio frequency ablation for this patient can be done.
Okay. For both GSV and SSV? For both great saphenous vein and the small saphenous vein?
Sir, if both saphenous systems are affected, we
Where
can
it is
still.
affected, you know? SSV is
Sorry,
4
sir.
millimeter. And even on the clinical picture also, you can see that in the calf area, there are
Sir.
prominent veins are there. Just show the picture.
Sir.
See here on the calf area, you can see.
Yes, sir. Yes,
So
sir.
it is because of the short saphenous system.
Yes, sir.
So you have to also tackle that also.
Yes, sir.
Okay, only tackling the GSV will not help.
Yes, sir.
Yeah. So,
sir, we can proceed with.
can you do the RFA of the short saphenous system also?
Yes, sir.
It can be done. Okay.
Yes, sir.
Okay. What are the other various techniques which are there?
Sir, minimally invasive techniques. We have two
RFA is a minimal invasive technique. Is it?
Yes. Yes, sir.
RFA
Minimally
is
invasive
minimal
techniques.
invasive. Yes.
Yes, sir.
What are the
Sir.
other techniques?
Sir, other techniques we have endovenous laser ablation, sir.
Yes.
And then we have ultrasound guided foam sclerotherapy, sir.
Yes.
And then we have mechanochemical ablation, and then we have endovenous glue application, sir.
Good. Now, what is a tumescent anesthesia?
Tumescent anesthesia we give for EVLA and RFA, sir. It is a mixture of 400 ml of ringer lactate with 30 ml of 2% lignocaine, and then 10 ml of soda bicarbonate, along with adrenaline, sir. Tumescent anesthesia along the vein that we are going to ablate, mainly to compress the walls of the vein and to protect the skin and subcutaneous tissue from the thermal effects which are likely to cause cutaneous burns. And then it also helps in hydrodissection of the nerves to keep it away from the vein that is going to be ablated, and also provides local anesthetic effect, sir.
Yeah. So what is thermal ablation and what are non-thermal ablations?
Sir,
What are
thermal
thermal
ablations,
ablations? What are non-thermal ablations?
sir, thermal ablations, we have endovenous laser ablation and radio frequency ablation, sir. Non-thermal ablation.
Any other you know apart from these two? Not very common, but they can be also used.
Sir. Endovenous microwave therapy.
Microwave is one, yes.
And then endovenous steam therapy.
Steam therapy can be used.
Yes,
okay. So they are the thermal ones, yeah?
Yes.
And the non-thermal, what are the non-thermal ones?
Sir, non-thermal, we have ultrasound guided foam sclerotherapy, catheter directed sclerotherapy,
yeah.
And then mechanochemical ablation, endovenous glue therapy, sir.
Good. Do you know any non-invasive technique for treatment of the varicose veins?
Sir, high frequency ultrasonogram.
Good. HIFU, you know? Yes. Now, in your center, are you doing the endovenous therapy?
Yes, sir. We are doing radio frequency ablation, sir.
You're doing that. Okay.
Yes, sir. As well as we have endovenous laser ablation, both of the modalities.
So, which laser you have?
Sir, radial fiber we use, sir. Laser.
You know which laser is used?
Diode laser.
Diode laser, yes. And what is the frequency of that?
Sir, 1470 nanometer wavelengths.
1470, right?
Yes, sir.
1470 is the commonest frequency which is used. You can
Yes,
use
sir.
980, you can use the 1920 also, but the commonest is the 1470.
Yes, sir.
Now, when you are putting the fiber inside that, what precaution
Yes,
is taken?
Sir, not to reach too close to the saphenofemoral junction, we have to keep the distal end of the fiber a little bit 2 to 3 centimeter away from the saphenofemoral junctions.
Good. Yes. And then up to what level you are going to, from which level you are going to approach?
No need to see.
Sir, from below knee level, sir, we'll make a puncture just below the knee, and then we'll introduce the laser fiber till 2 centimeter distal to the saphenofemoral junctions.
Dr. Kanagavel, can you please mute? Okay, thank you. Batao, how do you do that? Up to what level you are going to, from where you are going to approach?
Sir, from below knee level, just below the knee till 2 centimeter up to the saphenofemoral junction, sir.
Okay. Why not below the knee? Means more distal. Reason for that?
Sir, the saphenous now lies in very close proximity to the subvenous vein below the mid calf levels at school.
Yes. Okay. Because the saphenous nerve which is there.
Yes, sir.
You do not want to give the thermal energy there.
Yes, sir.
What complications can occur because of the endovenous treatment?
Sir, the patient might develop cutaneous burns if not sufficient or adequate tumescent is given, sir. So patient might develop superficial thrombophlebitis. Patient might also develop deep venous thrombosis.
What are the various non-surgical treatments for the varicose veins?
Foam sclerotherapy, sir.
Okay.
And then endovenous treatments.
You know, how do you do the sclerotherapy?
Sir, we use 3% sodium tetradecyl sulfate. We use Tesseri's technique to prepare the foam, sir. We take 1:3 or 1:4 ratio of sclerosant to the air, and then we agitate the sclerosant with the air using two syringes which are connected by a three-way valve. And then we agitate it for 3 to 5 minutes, and then we prepare the foam. And then using a needle, we have to locate the site of sclerotherapy, sir, by ultrasound guidance, and then we have to inject the sclerosant into the desired site.
Okay.
After injection of foam, each time we apply only 2 ml of foam, and then we apply tight compression over the area. Under ultrasound guidance, we are monitoring, we are keeping a track of where the foam goes and how far it goes, sir.
What is the importance of creating foam?
Sir, foam is able to encounter a much larger surface area when compared with the plain fluorescent, sir. And then it displaces all the blood that is existing in the venous column, so that all the foam gets, the whole of the vein gets in contact with the foam, sir.
In present day scenario, are there any indications for the open high ligation?
Sir, in resource poor setting, we can opt for conventional surgery, sir. Trendelenburg surgery with stripping of chasing and perforator stab avulsion.
And also for
See,
the very big varicose veins.
very big, yes.
Yes, sir.
Yes.
Okay. Diameter
Yes, sir.
is very
Yes, sir.
much more in the case of saphenous varix.
Yes,
In all
sir.
these cases, you may require the open surgery.
Yes, sir.
It can be 3 centimeter, up to 3 centimeter in saphenous varix. So in that case, you might have to go for open. Otherwise,
Yes, sir.
all you can manage.
Yes, sir.
Do you know what is the compression therapy for the varicose vein?
Yes, sir. We have medical grade stockings for varicose veins, are class 1, 2, and 3.
Yes. What is
Yes,
1, what is 2, what is 3?
sir. One is when the applied pressure is from 17 millimeters of mercury up to 24. Class 2 stockings exert a pressure of about 25 to 35. When the pressure is 35 to 40, it is class 3 stockings.
What is class 4? Where pressure is more than 40 to 50.
Okay,
And
sir.
it is usually used for the which type of the cases? In the
Patients with venous
lymphedema is there.
ulcer. Okay, sir.
Lymphedema.
Okay, sir.
That is the lymphedema, you can use the grade 4
Yes, sir.
stockings. Yeah. Any drugs which can be used for the varicose veins?
So, we can use pentoxifylline, sir. We can use flavonoids.
Yes. Flavonoids can be used. Pentoxapaline can be used. Okay. I think you have done so good.
Yes, sir.
Yeah, very
Yes,
good. Yeah, well
excellent.
done. Excellent.
Thank you.
Well, well read, well read.
Yeah.
Thank you, sir.
Dr. Kanagavan?
Kanagwell, sir.
Dr. Kanagavan? What are the complications of sclerotherapy?
Sir, sclerotherapy patient might develop allergic reaction to the injectant. Sclerotherapy patient might develop skin pigmentation or skin ulceration. Sir, patient might also develop superficial thrombophlebitis, or some part of the foam can dislodge and cause DVT, sir.
Mhm.
Do you know what is venous gangrene?
Sorry, sir.
Venous gangrene.
Sir, venous gangrene is the one which occurs when both the superficial and deep venous system of the limb are totally obstructed, leading to a totally impeded venous outflow. There occurs severe congestion of the limb, and there occurs severe hypoxia. The patient might develop gangrenes.
So that is why before doing any procedure for the superficial varicose veins, we should always look for the deep vein patency under Doppler, right?
Yes, sir.
What is Bisgard's regime?
Sir, Bisgard's regime, sir, 5 years, sir. We have to elevate the limb, sir. And then we have to make the patient exercise, and then we have to educate the patient about the disease. We have to evaluate the disease, sir, and then we have to apply elastic compression to the limbs.
Before you do the sclerotherapy, in which case you will like to evaluate the heart of the patient?
Sorry, sir, I don't. It.
Any condition where you will not like to give the sclerotherapy?
Sir,
Any heart,
patients with a right to left shunt, such as ASD.
Is the patent foramen ovale?
Yes, sir.
If the patent foramen ovale is there, then in that case there can be the paradoxical embolism may be there.
Embolism.
And so you should not do that.
Yes, sir.
Yeah. Can the sclerotherapy cause the blindness?
Yes, sir. Yes, sir. If the patient develops paradoxical embolism, it can lead to blindness.
Yes. It has been reported.
Yes,
Right?
sir.
There can be blindness after that, the sclerotherapy. Okay. Dr. Kanagavan? I think. Is Dr.
I think, sir,
Kanagavan
we
there?
can.
Huh? We can stop?
Sir was telling that there might be some issue with the this thing, his network or all, something like.
Okay. So, Kamaran, you want to ask anything from me or Dr. Parmar?
Sir,
But I must say
is
that you have done extremely well. Extremely well.
Yes. We must admit that you have done extremely well. You are
Thank you,
well
sir.
read and you know the things. Very good. Excellent.
Thank you, sir.
Okay.
So if you don't have any questions, sir.
Yeah, we can call off now. Yeah.
Yeah.
Dr. Kanagaval, are you there? I think let us say goodbye.
Yes, sir.
Bye.
Goodbye.
Bye. Bye.
Yes, sir. Thank you, sir.
Thank you.